Welcome to Hidden Diagnosis Impact. The podcast uncovers the often overlooked and misunderstood conditions. From EDS, CCI, and beyond, we share stories and insights from those living with these conditions and healthcare professionals dedicated to diagnosis, treatment, and research. Join us as we uncover the reality behind these hidden diagnoses. Here is a podcast title update. Previously named Occult Awareness is now Hidden Diagnosis Impact, to better reflect our mission of revealing and understanding overlooked medical conditions. In today's episode, we have Kiera Chan, a public health PhD student and patient advocate, share her journey through the healthcare system. She combines personal experiences with professional insight to highlight challenges, advocate for treatments, and address healthcare disparities. So welcome again, and to helping us to understand and empower us in the journey towards advocacy and awareness.
Thank you.
So would you like to just start with sharing a little bit your journey as a patient advocate, or just how you started to really study in the area of public health?
Yeah, of course. So I actually started in public health before I ever got sick. I got sick a few years ago, and that's when I started becoming a patient myself. But actually, when I was 15 years old, I had read an article about how girls miss school because of their menstrual cycles and lack of availability of menstrual products, and how that impacted their school attendance in low-income countries. And then I started to sew menstrual pads and products, and I sent them with my friend to a girls' orphanage in Ethiopia. And after I sent them to that orphanage, then lots of organizations started reaching out and asking for more products. And I realized this was going to be so much bigger than I thought it was going to be. And I knew that I wanted to dedicate my life towards public health or health issues. And so then when I was 19, then I did a TED Talk, and I talked about kind of that same issue on menstrual poverty and about menstrual stigma. And when it was posted to the TED Talk website, then there's I guess just a lot of people viewing it from all over the world, and they started reaching out to me. Mm-hmm. They were telling me about menstrual health issues, like premenstrual disorders and their health issues. So I realized that was something that needed to be talked about. And so when I started to do my master's in public health a few years ago, I started my own study on premenstrual dysphoric disorder. And I asked about patients and their experience of the healthcare system. And the most major finding from the study was that patients, even if they had an official diagnosis, they were still misdiagnosed and they were dismissed. And the only time that they're able to get treatment or an official diagnosis is if they had a self-diagnosis. They always had to self-diagnose, essentially. And I thought that was pretty major, but I was wondering if this was only in menstrual health conditions or in other conditions as well. And then later, I think the next year, that's when I got sick myself and started to become disabled. And I realized that dismissal was kind of universal, and I wanted to look at that in my PhD program. And so this is my first year doing a PhD in medical sociology. And so essentially I study the healthcare system.
Wow. Yeah, this is seems like a very interesting journey into how you actually study public health, noticing the difficulty of diagnosis and difficulty of finding out. So can you just elaborate a little bit more on that side of being a patient and unable to really find anything on tests?
Yeah. I mean, when I first got sick, it was during COVID, so it was really hard to get care. For instance, I was 21 years old. I just turned 21. And I would go into Addisonian crisis. And my mom would drop me off at the ER. But they weren't allowing any visitors in. And so I'd just be unconscious, and no one even knew my name or my birthday or what was wrong with me. And I would sit in the ER hall for hours and hours. And it was really terrible. Then I get admitted, and I would go into crisis while I was still admitted, and I'd like press like the call button. No one would come for hours and hours. I mean, they're severely understaffed, but it's just a really difficult time. But later I was able to get my mother to be my medical power of attorney. But that's when I realized, I, like, I was like, what do other patients do if they don't have that? You know,
Yeah.
they could even die while in the hospital if they don't have a patient advocate or power of attorney with them. And that question just kind of haunted me all the time. And I think about that all the time, just about the patients who don't have insurance because I had insurance, who don't have access to medical care because I did, patients who don't have someone to help take care of them, or maybe who don't even speak English or English isn't their first language. Because for me, I was getting my master's in public health, so I was pretty educated, and knew about the healthcare system, but I still couldn't navigate it. And I still was being dismissed over and over again.
Yeah. Well, that's why I feel like as a patient that you experience all that and suddenly, like for me, even feel really concerned and then realizing that this is really a global issue. It's not just really in the United States. For understanding, like I know that you probably also you had a CSF leak, right?
Yeah,
Um,
I do.
and was that easy to diagnose?
Oh, no, definitely not. I've been having CSF leaks for 4 years now. Um, I still have one right now. Luckily this year I've been able to get 3 blood patches, but they still
Mhm.
haven't worked. Um, but when I first got a CSF leak, one of my providers, they're like, I think this is what you might have, but they weren't able to actually treat me or do anything because they weren't like that type of specialist. They just had like kind of a hunch about it. And I thought, no, 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 that's impossible. Because nothing actually happened to me. It was a spontaneous leak. But then later I kept thinking, no, this is definitely what's happening. And I probably went to maybe 50 or more neurologists and neurosurgeons that year, but I wasn't able to get any help, and they would just tell me that I'm crazy. Um, I went to the Mayo Clinic too, and they were not any help at all. So uh, it's interesting because a lot of times in the research, they talk about like, well, it's just conditions that don't have objective evidence that are dismissed, or conditions that are chronic illnesses. But CSF leaks it's not a chronic illness, it's acute. It has a pretty easy treatment. You can see it on scans, but I feel like those patients are one of the most dismissed patients. Um, it's very, very hard to get diagnosed and treated, and patients suffer for years. So,
Yeah.
yeah.
Well, and on top of that, I actually had CSF leak as well for a couple of times. And I did watch a lot of conference and everything talking about this. And do noticing that a lot of time with testing that you really have to have experienced expert in this field to read the scan. And
Yes.
sometimes, yes,
Yeah. Oh, go ahead. Yeah.
sometimes they also will have like special type, like the fistula,
Yes.
right?
Venus fistula.
And so you might not really see it if you're not careful. So often the things that are on research papers are more of a typical type of symptoms or um, a patients.
Mhm.
Some audience may be familiar, but some might not. Can you explain a little bit more about occult conditions and like orphan disease?
Yeah. Orphan diseases are like rare diseases that don't have a set treatment or are under researched. And they're very hard to diagnose.
Like we always mention about occult, the things that it just doesn't really show on imaging. And this it's such a hard time for the patients to even know what's going on, and then seeing all the tests normal and coming back tell you, oh my God, like your tests look great. So as patient yourself also, like those experiences that you encountered for you and how that really impact your advocacy work or your even your PhD studies?
Yeah, definitely. Even just the stories that I hear every day, it's very impactful. I think our healthcare system is designed in a certain way, and we think that if patients are sick, then they can go get the healthcare that they need. If they have access to healthcare, then they can get the healthcare that they need. And as a public health practitioner, in public health research, we often talk about healthcare disparities and access to healthcare. So if patients have insurance, if they have transportation, if they have health literacy, like if they understand, how to navigate the healthcare system,
Yeah.
then they're like, well, then they get the treatment, right? That's how our healthcare is supposed to be designed. But for me, I see that that's definitely not the case, especially with patients with rare diseases and complex conditions like this, that our healthcare system is routinely dismissing these patients.
Yeah, so I know that often those issues come immediately right after ER visits. And did you experiencing anything similar to that, or did you noticing this to be somewhat a phenomenon?
Yeah, definitely the ER is not designed to diagnose especially complex conditions. And it's funny because a lot of ER doctors themselves will say, this is not our job, right? Their job is to do like life-threatening stuff. And even if you do have something life-threatening, but it's like super complex, their job's just to rule out. And they're not really trained as diagnosticians. And they only have like some resources on their hands. Also, a lot of times ERs, they have like a protocol or like minimum of however many patients that they're supposed to see or have in their beds. And so they're trying to push patients out of beds and clear them out by a certain time frame. Um, but the problem is what they don't realize is that patients will try to go to their primary care doctor and their primary care will say, well, we can't treat you, right? And then maybe they are able to get into a specialist, but the specialist will say, well, if you have something going on, then just go to the ER. And they'll tell them to go to the ER if they have something going on. And a lot of patients are waiting months and months to see a specialist. Um, so that's often the only choice that patients have. And that's not even to mention the patients that don't have insurance, which of course they will go to the ER because the ER is required to take them. So it's really a catch-22 for patients.
Yeah, I noticing myself didn't want to go to ER, like, after every single time going there and then come back 2:30 in the morning and not really getting anything, really.
Yeah.
So did you actually went to ER first and then you said they sort of didn't have idea, did they actually every single time being able to admit you, or was that there was times also like having difficulty and very much of gaslighting?
Yeah, there was very few times when I was actually admitted. Most times I was discharged. I think the only time I was admitted was because I hadn't eaten or drank for more than 2 weeks. I'm not really sure. It was a really long time, so that's the reason why. But the other reasons, which probably I should have been admitted, like going into Addisonian crisis over and over again, they didn't admit me for that. And a lot of times, even when I was admitted, I was still discharged with no care, or they would do an MRI or something, and they'd be like, "Okay, you're fine. You don't have a pituitary tumor, so congratulations, you're healthy now." So,
Wow. Well, that's yeah, it's really crazy how like they just send you home with sort of like having a reason that it's like it's not crisis. Can you excuse me? So I need my dad to plug in the power. I think he's really exhausted, if we be honest, like the last couple of weeks. And then I start this whole thing and he's like, oh my God, I'm gonna set you up. And then and then we forget things along the way. So
oh, I definitely understand. My mom's
yeah.
my caregiver, so I
Uh,
get it.
it's lucky that we have family member that can actually take care of us. But a lot of many patients that couldn't really have that resources. And so, like, what would you say to people who didn't even have insurance or didn't have that kind of care resources that they can really go to?
So if patients don't have insurance, then I would, I mean, it's very difficult, but trying to get on some sort of subsidized insurance or government insurance like Medicaid. Um, yeah, there's a lot of barriers for that, but I guess that's better than nothing. Um, I mean, there are doctors like naturopaths that are very expensive and they don't take insurance.
Yeah.
But a lot of times I tell patients, if you're having trouble getting diagnosed and you're just, you've hit a brick wall and doctors have stopped trying to order any tests or anything, then go to some kind of like holistic doctor and have them, because they'll just run every test imaginable. Of course, I wouldn't actually go to them after that. Once they've run the test, don't actually go to them for treatment because, anyways, whatever. I'm not going to give medical opinions. If you want to, go ahead. But I would go to them just so that they would run all those tests, because that's what they usually do in the first appointment, is run all the blood tests and see like what's low and stuff. And then I would take those tests to a doctor and show them, because yeah, a lot of times naturopaths are like, trying to think outside of the box. So that's definitely one option, but a lot of times it's not affordable for most people. And then if you don't have anything, I think that the online support groups or online resources are very, very helpful. Me personally, the only helpful doctors I've ever been able to find are from the recommendations of people from the online support groups who have found doctors. Um, and so just being able to get their recommendations and what their treatment recommendations are, that is very helpful.
Yeah. Well, I actually got a lot of help with those online support groups. And there's a lot of amazing people that are really willing to help you, at least for the resources and then anything that they can find online. And so, besides that strategy, and have you found anything else that is effective in advocating for patients with, just lesser non-health conditions?
Yeah, so I would say um, off-label treatments are one of the main treatment options for patients, because often with rare diseases, there are either just no research or no treatments. And so a lot of the treatments that would work for them are often off-label. And so being able to get those treatments is often key to actually getting treatment whatsoever. Um, and so to do that, you can you are supposed to fail all of the possible treatments, right? And so I would say, have your doctor prescribe those treatments. And even if you don't really want to take the full course of them, just say, hey, I had these horrible side effects, and make them write that down in your chart, and show that you failed all of those treatments. And then have the doctor do an appeal to insurance or to whatever to get the medication that you want that is off label. And for those of you who you don't know, off label is like not what it's meant for, not what the FDA approved it for. So, yeah, definitely also doing most of the work for your doctor by like writing the actual appeal letter is also very helpful. I definitely had to do that many times, and just writing the reasons why your insurance should cover it. And even just saying, well, having this medication will help me to, like for me, I say not go into Addisonian crisis so many times, so then I won't be going to ER. The ER is super expensive for insurance to cover. So then, it's in their best interest to cover this off-label medication, right?
Yeah.
Um, and yeah, I'd also say if you can't travel out of state, try to do like telemed from out of state. So request and like describe your story and maybe try to like appeal to that doctor, even if they don't normally do telemedicine. You can say, hey, this is my problem. I've been trying to get treatment from all over and I can't afford to travel out of state. Would you make an exception for me? A lot of times they might, you know? Um, or a lot of times what I do is sometimes you have to go in person to that first appointment. But then the rest of the appointments, then I ask them if they can do telemedicine. And so I don't have to travel. And that's probably what most patients do. But of course, that's very expensive and not feasible for most patients.
Yeah.
I would also look up research and actually print it out and give it to your current doctors or local doctors. So even if you just, all you have is a primary care, for example, and your primary care can't treat you because they don't know anything about, for example, EDS. They don't know anything about these rare diseases. But you keep going to your primary care and you update them on your health conditions and how you're doing and how you're progressing. And so they kind of feel like they're part of your life and they start to care about you because you keep updating them. Maybe you message them through the patient portal, whatever. Um, and then you tell them about your quality of life. Like, tell them, hey, I used to be a full-time student or full-time employee. Now I can't even get out of bed, or now I can't even eat. I've lost all this weight, blah, blah, blah. And you appeal to their emotions, appeal to them and relate to them. So, for example, I'm a university student, so I go to a lot of university doctors and I tell them, hey, I go to this school. I'm a student here. I'm trying to just get through my program, and I really need you to just help me do that. And a lot of times they then feel invested like in your success and they start to care about you. Um, and just tell them about those personal aspects. And you don't have to tell them like, hey, please heal me, please cure me. Just say, hey, I just want a better quality of life. And then once they start to, actually care about you, like in that way, then maybe they'll be willing to, for example, prescribe these off-label treatments. So if you hear from someone off of a support group that this treatment has worked for them, then you go to your primary care doctor and ask them, hey, can you prescribe this? And sometimes just I appeal to them by saying like, hey, like you're a father, so what would you do if this was your daughter? And at that point, then they're like, oh, okay. So,
Yeah. Well, so the problem is that I feel like because I didn't grow up in the United States, and so it's sort of like all new to me, and so I was just stumbling around and trying to figure it out myself. And I did noticing that the difference a lot of time with Chinese medicine and the Western culture, it's just like a lot of time you're treating the symptom, right? Like it's kind of management and then like putting a bandage on whatever the real cause is. And but often like physician couldn't really see the root cause. So for example, like the instability things. So that all manifested all over the body and it's hard to see where is the root cause. And would you say that for patients to kind of like, I mean, of course it's their choice, but would it be more wise to really dig into the root cause and then exhausting yourself, burn out, or like, oh, I'm just gonna, be comfortable with those symptom management?
yeah. So I would say most patients who don't ask for a cure and they're saying, I just want better of quality of life management. Most of those patients I run to are patients who are disabled and they've been disabled for a long time. It's kind of like if you meet someone who um, got spinal cord injury from a car accident, and then you ask them, hey, what would you rather? Would you rather to just, I don't know, go to the bathroom like normal or to be able to walk? They're probably gonna choose like, if you had to invest all this money into one type of treatment, what would it be? And so a lot of patients who have been suffering for a long time or are severely disabled just really want better quality of life because they know that they haven't been able to find a cure yet, or maybe a cure doesn't exist. So definitely if you have first been diagnosed or first started getting sick, definitely look for that root cause. But if you're starting to get burned out and if you've been really sick for a long time, then uh, yeah, I mean, it's your choice.
Yeah, I think in a way that it's sort of like choosing mental health over like the physical like a cure, right? The word of cure often not really it's difficult for finding all these reasons and finding all these solutions. And I actually had just conversation about how sometimes that solution that you think it is, that might not be the end solution. So it's just one step further down. And yeah.
Yeah, I agree. And I think the reason why I say that, focusing on like quality of life or symptom management, is because when you go to a doctor and you ask for a cure and you come in with this disease that they aren't super familiar with, then they get overwhelmed and they say, sorry, I can't treat you, right?
Mhm.
Or, find someone else. But patients are desperate and they really need at least some doctors on their team. So while they are trying to find a doctor, and that might take, I don't know, a long time, they still need some doctors on their team to help them manage their symptoms. And so if you go to a doctor and tell them, I just need XYZ, like you go to a gastroenterologist, I just need, you know, to be able to eat right now. I don't need you to cure me. So that's just telling your doctor that, but you in your head can still think, no, I want a cure and still look for that cure. But that's just kind of how to communicate to a doctor so that they won't get overwhelmed with like the complexity of your condition.
Okay. So that definitely leads to one of the questions that I feel like many of us that have experienced is those very easy uh, labeling of functional neurological disorder because of how complex everything looks like. And what's your opinion on that? Is that really feel like it's just so overly diagnosed?
Yes, I definitely think that, any patient who has this diagnosis and is comfortable with it, that yes, go ahead, that's your diagnosis. And I mean, I agree that patients need a diagnosis um, to get the treatment that they need or the accommodations that they need. So even if they have FND, and I don't personally agree with it, I think that it's definitely necessary for a lot of patients. But because I study the healthcare system, I see that doctors are using this to curb overuse of healthcare resources. And so doctors see patients coming in over and over, and they can't find a diagnosis for them. And so they will give them what is called a contested illness. And in the literature, a contested illness is something that does not have an actual etiology that we know of. It doesn't have objective evidence, so it cannot be seen on an MRI or blood test, scan, etc. So it is things like fibromyalgia, FND, ME/CFS, all those things are contested illnesses. And while I think that those illnesses are correct, like they do exist, we just don't know the etiology yet or the actual treatments for them yet. And there's probably a lot of subsets of things. So FND or a lot of contested illnesses are used to label these patients so that patients have an answer and that doctors can say, hey, look, I diagnosed this patient. And they kind of feel better about it because, they don't have to say, I don't know. Um, and this is kind of what doctors are being taught now because ordering expensive tests over and over again and ordering these tests and having a patient come in over and over again is not ideal for the way our healthcare system is designed. So a doctor wants to see lots of patients to get paid more, right?
Hmm.
But they can see like 10 non-complex patients in the time span of just seeing one complex patient. or one rare disease patient. And so they're going to try not to see those rare disease patients unless, that's their actual specialty, right?
Yeah.
And also the treatments for these contested illnesses or like FND are very inexpensive treatments that are easily prescribed and that you don't have to jump through a lot of hoops to get to. And so doctors can easily prescribe something like um, an SNRI. I think that's one of the medications, right?
For the
Um,
FND, I do not
or
know.
SSRIs, SNRIs.
Yeah, maybe SSRI, like just treating, they
Anyways,
think they
yeah,
have depression, maybe something like that.
a lot of them are things like, yeah, like the nervous system ones and SNRIs, but those are very inexpensive medications compared to like, for example, you obviously don't have FND, but your condition, you need like lots of surgery, so a procedure is going to cost more. So that's just an example.
Okay, yeah. I I mean, I do see that there is issues with misdiagnosis or labeling them, and while they don't get better with, like you said, really cheap treatment. And so they're still gonna go back to the doctor over and over because eventually they kind of just exhausting the whole entire health system. But in that sense, I feel like, what is the problem regarding to diagnosing those conditions? And does that feed into a lot of doctors who actually having those gaslighting or dismissal behavior, or is that just really not acceptable, really in general, to have those kind of behaviors within the doctors?
Yes. My research is on patient dismissal, and I conceptualize misdiagnosis of psychosomatic conditions or misdiagnosis of contested illnesses as a form of patient dismissal because it is dismissing the patient and saying that it's on their head or it's giving them just like an easy band-aid solution diagnosis when in reality they have something else.
Yeah. So, did you also noticing any problems with charting system while you're researching it?
Medical charts
Yes,
or
like a like
yeah.
medical charts charting with office notes.
Yes, and this is one of my most frequently asked questions or like topics that I go into on my Instagram is contesting something. And so um contesting something off of your medical chart or contesting a diagnosis is something that so many people, want to do. And so to do that, it is very hard often, but you can try to contact patient records or patient like customer service, and they'll send you to the correct person to request to amend protected health information, and they'll put an amendment in your chart. And then you can also ask your doctor to put an amendment for you. And either they will just like get rid of whatever that diagnosis is, or if it's like an actual note or something, they can often put a note like on top of it or some kind of like addendum where it says, oh, this was incorrect because it later found that the patient actually has epileptic seizures and not like those psychological seizures, for example, or the doctor can actually put that in. But yes, it is, once you have something in your chart, it's very hard to get off, and everyone can see that.
Oh yeah, what if it's a subjective like opinion from the doctor, and then you do want to say that it's not really the fact, and the doctor is not helping you to really change the amendment?
Um, I mean, I haven't specifically fought those, and doctors are allowed to make their own opinions and like make notes about a patient, like, oh, this patient looked, I don't know, put together, so it looked like they were not sick, or this patient was crying, so they have depression or they need a psychological consult. So that is actually something that it's allowed for doctors to do. Doctors are allowed to make their own subjective opinions and put that in the chart as just like their charting. And a lot of times they think that this is just, some kind of helpful description or whatever. But a lot of times it does color other people's opinions and can make people biased.
Yeah. So I know that you mentioned in one of the video about how doctors now this whole entire medical system it goes against like how thinking out of the box. And can you explain a little bit about that?
Yeah, doctors are not really taught to think out of the box nowadays. I would say maybe a decade ago or more than a decade ago, medical school was a little bit different. But now healthcare has changed a lot. So there's a lot more healthcare actors in place. There are more insurance companies, there are government agencies, there are healthcare quality management agencies. There's all these different players in the healthcare system. So it's not just hospitals and doctors, and that's what it kind of used to be. It was a more simplistic model, but now it's very complex, and every actor within the system has different interests, right? They have different interests, and so they're pressuring doctors, especially doctors, from all different angles. And so doctors are supposed to do this, do that. They're supposed to meet these different requirements. They're supposed to meet protocol. And a lot of doctors work for organizations, and so they're meeting those organizational requirements while also trying to meet patient needs. And that's very difficult to balance. So a lot of times, I don't think it's doctors' faults at all. I mean, there are some rude doctors, obviously, but I would say a lot of doctors are just trying to do their jobs and not get fired. And I actually know of doctors who have gotten fired because they have tried to do out of the box treatments or tried to treat rare disease patients. And the clinic or organization they work for, they don't like that.
Wow. Is the organization didn't like that and they get fired?
Yes. And then they can also revoke their medical license too.
Wow. Yeah, I kind of know the case that I was pretty much involved right before that the person got fired. And they're really great doctors and they really see real patients and see the symptoms and they know what's going on. Also, they are very smart in that aspect. And but the unfortunate thing about this outside of box thing, like because we never really fit into any box, right?
Yeah.
So do you think that subdiscipline nowadays with all these specialty like neurology or I don't know if anything else, especially in neurology, there are so many subdiscipline that does that really do harm to the patients, especially with complex cases? And what do you think that, like in terms of like patients that what they can do?
Like being dismissed or
Just in general, like you don't fit into any,
oh yes.
yeah.
Yeah, so I talk about that in my research because often the research that exists now on patient dismissal is like, oh, it's just a rude doctor, or, you know, this is just some kind of medical mistake or something like that. But for me, I'm showing that it's actually not really a medical error as seen as a traditional medical error because this is seen as good practice. It's seen as good. For example, if a doctor gets a complex patient,
Mhm.
they'll say, yeah, this is outside of my wheelhouse, so I can't treat you. And that's seen as good because right now doctors don't want to step outside of their bounds because then, yeah, they will get fired or, they will be stepping outside of their uh, what they're supposed to do. And so maybe their boss or other doctors will look at that and be like, oh, yeah, that's good that they dismiss them because, yeah, that's outside of their wheelhouse. So the patient needs to find someone else to treat them. But what they don't realize is that it's outside of everybody's wheelhouse, right? So the patient is just constantly hearing this and they're constantly being dismissed. But yeah, that's what I'm kind of looking at is these are things where doctors are actually not only taught to do this, but are praised for doing this. I actually was talking to an older doctor. He was an older gentleman, and I was telling him about this surgeon who dismisses patients, but it's more of like saying, "Hey, I can't do follow-up care," that kind of dismissal, where he does surgery on patients, but he doesn't do follow-up care. He only sees new patients to do surgery on. And that's seen as great because he's making the organization more money because follow-up care doesn't pay that much, but surgeries pay a lot. And so he's taking in a bunch of new patients, but he's not seeing his old patients. And he tells his old patients, you need to go to the ER if you have complications, or just go to your primary care or your local doctor. But the problem is the ER is not going to do anything for them. The local doctor is going to be like, well, I didn't perform surgery on you, so I can't help with your surgical complication. And the older doctor that I was talking to said, well, that sounds like a lot of patient abandonment, like what I would consider patient abandonment. And I said, yeah, but to that doctor, it's not patient abandonment, right?
Mm.
So it's very subjective.
It's kind of like from which side of perspective. Yeah.
Definitely.
So yeah, looking at that, and I feel like, with all these research and advocacy from the patient, and always telling patient that you need to advocate for yourself, but then with complex patients, that those kind of behavior happens and as a good practice. And what you think that in this whole entire research that you're hoping out of, like what can help the patients actually?
In terms of advocacy, I really wish there were more patient advocates out there. For instance, most hospital systems have a patient advocate, but normally they are only on call uh, during work hours. So, after 5 p.m., they're not working. On the weekends, they're not working. A lot of times it's only one or two patient advocates in the entire health system or hospital system, right?
Yeah.
Um, Also, those patient advocates, I mean, I've talked to them. I don't think they're paid that much. They are definitely trying to balance the needs of a lot of different patients. And the problem is that they also work for the hospital. So that makes them like a little bit biased. So you might run across a patient advocate, but they're trying to kind of just manage some tensions or some conflicts and kind of smooth things over. But maybe they don't actually advocate for what the patient actually wants because that might be too difficult or going against like some kind of protocol or rules, right?
Yeah.
So I would love to see a system in which not only there are more patient advocates, but maybe they're subsidized by the government or paid by the government, or they're like a whole separate entity.
Mm.
And that automatically, if you are a patient of low income, or you English isn't your first language, or maybe you're a complex patient with like a bunch of different rare diseases, anything that makes you a vulnerable patient, then you become eligible for this service, and then you get this, I guess, patient advocate service. So that would be my dream for the healthcare system. Obviously, I don't think we have the resources for that.
It's difficult. It seems like there's really, really complex systems right now that for really the doctor to change the attitude. Uh, yeah, and it's very surprising to see because of how much of work you have done on your end to understand this whole system, that how it's internally interconnected and dependent on each other.
Yes.
Yeah. And I mean, so for everything we talked about, I know that you learned so much about this whole entire system and how to really help patients. Now, as a patient yourself, I know you've been through a lot. How do you emotionally feel and after going through all?
Well, I really feel empowered as a patient and as an advocate because um, I feel lucky because I'm able to um, get to make this my career essentially. I was already studying the healthcare system, and then I got sick, and I was able to kind of pivot and turn this into my career. And I'm really hoping that I can help other patients with my research. But I definitely wish that there are more resources out there for patients. And I myself am learning every day, and I'm learning from other people and learning my program, new strategies. And so I just want to be able to share that with the world because obviously not everyone can get a PhD in studying the healthcare system. And it's honestly kind of ridiculous that even with my education that I'm not able to navigate this complex healthcare system because it is so complex.
Mm-hmm. And do you feel like patient is now sort of like one of the outsiders of the whole system because, like everyone's kind of profit on it and benefit on it, but we seem dumb.
Yeah, I actually am looking into this because right now our healthcare model is kind of based on this consumerist model, right? Where patients are paying all this money for healthcare and it really depends on, how much you're paying, right?
Mhm.
Whereas other models are more socialist, everyone gets kind of like equal care. Of course, you can pay more and get like privatized services and stuff, but essentially, the US healthcare system is consumerist and based on this capitalist model. But you would think that because of this model, patients are consumers. And within an actual economic model, consumers have power. But what happens is our healthcare model is not like a normal economic system because it doesn't follow market-based dynamics or market rules. For example, a normal market has competition, but in our healthcare market, there is no competition. There are monopolies, and we allow that in the US. Um, the patient is in a situation where they're just trying to get healthcare as soon as possible and they don't care where, when, they just want it now and they're dying and they need it right. And they're put in this
Yeah.
position where they're vulnerable. And so they'll do anything to get it. Whereas in a normal market, consumers shop around for the best prices or for the best quality. And they have transparency of prices. They can see what everything costs. But in our market, we don't have transparency. So everything costs different and you can't see the prices and you don't know what it costs. So for example, in Japan, there's like an actual like book that sits on the desk of every clinician and it has all the prices of everything. They can just look up and say, oh, you need an MRI. They'll look it up. Okay, that's like $200. In the US, an MRI is like a couple $1,000s, right?
Yeah.
And so you can how much it's inflated because of our system. So patients actually don't have power within our model. They can't be consumers of their own healthcare. They can't choose, right?
Hmm. Yeah, this is so unfortunate. I feel like we don't really have a clear book when we go to ER and knowing how much come out of it. Even you ask the registrar, they're like, we don't know.
Yeah.
And but it all adds up, everything. And so this is very scary, especially without like a an insurance work in that inpatient or in network setting. And then so we are always being charged more. We are sort of like the only one that it's so out of control, not just our health, but everything um right now.
Yes.
One thing that I'm noticing that when we talked about the strategy and everything, you said, oh, patient needs to do more research on their own and, they need to bring to their doctors. Um, but often what I see or what I hear is that you bring to the doctor and the doctor is looking at it as showing they're
Yeah.
looking at it, but they don't really want to read. And in that sense, like, we really cannot communicate with the doctor. And was that also because of the system causing that for physicians to do it? And what at that point, like, patient can do?
Yeah. A lot of times doctors want to do what they've always done. So they don't want to do something that's never been done before or that they themselves have not done before. Or if they haven't heard of it, then they're probably not going to look into it. So that's why I said try to get your doctor to like care about you, or be invested in your care, because then they're more likely to actually like look into that research that you bring them. But no, if it's not like the doctor that cares about you, like your primary care, then they're not going to probably read it, right?
Yeah. Yeah, I know. Like, the one thing that I noticing is just sometimes they feel like they're not experienced with whatever they need to treat you, and they rather kind of dismiss. And then I don't know if that's where the dismissal come in.
Yeah, it's because of liability pressure about patient life if something goes wrong. And so that's why patients a lot of times are dismissed, because it's more liability to have that patient like as your patient. For example, if you're super, super sick and then you're like, hey, I need a doctor, they're going to be like, no, I don't want to be your doctor because they're like, that's more liability for me, right?
Mhm.
Whereas if it's like a healthier patient, they're like, okay, sure, I'll treat you. So, yes.
So I know that even there was interviews mentioned about, oh no, like I don't want a doctor shopping because then people like talking about how I'm just going around and having second or third opinion. What's your take on that?
Yeah, no, definitely. They don't like too many cooks in the kitchen, right? And so when they know that you've been seeing like another doctor, then they get really upset and really defensive, and it hurts their feelings. So I would say see a doctor within like one hospital system and then outside of the hospital system, for example. And so if the doctor asks about it, then you're like, well, I need a doctor. So if I go to the hospital, then, I have someone like an endocrinologist to manage my care. But then I have this person because they prescribe me XYZ medication. Or maybe the doctor in the hospital, they don't have that many appointments, right? Because they're so busy and you can only see them every 4 months. And so you're like, well, I need just someone. So if I have an emergency, they can like prescribe me whatever, right? Multiple titles. So sometimes they do internal medicine and they do gastroenterology. So you'll say, oh, okay, that doctor actually enterology, and so that's why I'm seeing them. And so you kind of explain it like that.
Oh.
But that's only if you're confronted about it. Otherwise, I mean, they probably won't find out, right? But just tell them, I need a doctor for example, I myself have a reproductive endocrinologist, but that's someone to prescribe me like hormones, right? I have a regular endocrinologist to manage my care. And then I have, um, I'm not really sure. Anyways, I have a different type of endocrinologist. And so I just say like, oh, well, this endocrinologist is for something else, right? And if the endocrinologist who finds that out, argues with me or is like, what? I want to be your only doctor. It's like, okay, then you can manage everything. And then a lot of times they'll like back off and be like, oh, never mind. That's too
Oh,
much work. Because it is a lot of,
yeah, I see. So I never really had like multiple endocrinologist because still waiting on the line for one of the internal medicine doctor. And but I can see that like, but also in a sense, like they always say patient doctors like two-way, like you can always choose them and they can choose you. But from what you were saying, and that kind of really makes sense that they also human and that they really wanted to be respected as well. And so with the language or the way that you're talking to them, I think it's really important. Um, yeah, and it was awesome to really, talk to you and be able to really share the knowledge about how patient can get the good, at least like decent amount care to get better quality of life. I think the quality of life come down to the bottom. It's the most important. That's what patient wanted. But we do sometimes feel very righteous about how we don't get right diagnosis, right? Um, what would you do if it comes back to be misdiagnosis and um, when you for certain like saw a specialist and then it turned out to be a completely different idea as a GP, like, you know,
Like, what would you do to the doctor who misdiagnosed you?
yeah,
Or,
if you still have to see them.
oh, yeah, I would just say, oh, hey, I got this test result and it turns out this and that. And you don't have to say that you're wrong. Just say like, oh, I have this. And so I think that you have maybe both diagnoses. Or if it's a problematic diagnosis like FND and you want it taken off your chart, then just ask politely for them to take it off your chart.
Yeah.
And you can have evidence like show the test results, or even like the doctor who diagnosed you, they can write you a letter and say, oh, due to new test results or new information, we found out that the patient has XYZ condition, and you take that to your other doctor. And doctors are more likely to listen to other doctors. So
Yeah, sometimes not might not be the case, but I
maybe
just
that.
I know there are certain patients definitely worry about the fact that becoming having the diagnosis of FND and then becoming having no proper care because they often don't. I mean, it's not just here, but especially over like a lot of smaller countries, and then the problem of the healthcare, and they often getting labeled, and then they don't really get any um, healthcare, including their equipments and things that they need.
Yes. In the literature, that's kind of called like diagnostic overshadowing. Of course, that relates to like an actual diagnosis and not a misdiagnosis, but it's kind of like when someone with cerebral palsy goes in to get care for UTI, and then they're told, oh, it's just your cerebral palsy symptoms, right? It's the diagnosis that overshadows everything. And even so, patients aren't able to even get just basic care, like I said, like an infection, because they see that you have that diagnosis and they just blame it on that diagnosis. So that's a real problem.
Yeah. And currently, is there anything that can really help them to at least like getting the basic care? And how do you feel a lot of patients might really having treatments for their, for example, a structural issue, but not able to see because it's all standard MRI, right? And then we always talk about how important is upright MRI and stuff. And so these patients being left in palliative care and then just thinking that, well, that's just their end of life. And I know that I feel really strongly. That's why I started the podcast. But then I want to hear a little bit about you that how, you think that there's anything that might help them, or is that seeking for more treatment or diagnosis might be better?
So if you are suggested palliative care, I personally think that, well, doctors say that if you are in palliative care, other doctors refuse to treat you, right? Or they definitely won't refer you out to specialists, they won't treat you. And so if you can try to resist being put into palliative care, because they won't treat you. And if you need some kind of symptom management or pain management, then I'd go to like a pain clinic or a pain doctor to see if you can get that instead. Um, because that's how our healthcare system is designed. When you're palliative care, then they won't treat you anymore.
And as you said before, that they just would move on to new patients.
Yes.
Yeah. So maybe one hopeful little end of something that you want to mention about, giving patient a little bit more hope on the future system and the possibility of research?
Yeah, I mean, I feel very hopeful because this is a new day and age when patients are able to connect with each other from all around the world, and patients are able to see research in real time. I mean, a lot of patients, I mean, even you mentioned going to conferences and stuff. I don't think that really was a case, 20 years ago, for example, right?
Yeah.
So patients can go to these conferences, or even if you don't actually go to the conference, you can look up, for example, last year's um, CSF Leak, whatever it's called, CSF Leak something conference, right? And then you can look at the schedule and see who the speakers were. Look at the keynote speaker and look up who they're affiliated with. Look at their research. You might even be able to look at their email if they work for a university, right? It's like their first name dot last name at university.edu, right? And you can email them and they might even email back, right? And I think, that's very hopeful because, um, especially as a researcher myself, I see more and more research coming up with these conditions. Um, and even the research that I'm able to do right now, I'm trying to look in to see how patients are being dismissed. So we can see that this is a systematic flaw in our healthcare system. And so patients all over the world can actually try and participate in research that's happening, if they can. For example, I I don't know if you've heard of rare patient voice.
Yeah.
And so their research studies, and then just, if you're looking at the local university, whatever research studies they have. So, and it doesn't even have to be like clinical research, right? A lot of the research I do is just like surveys and interviews.
Yeah. Well, I think that's great. And if you can actually share a few of these researches about patient dismissal, and then yeah, that would be great. And I think that would be very helpful for us also to look forward to any kind of changes in at least, like, empowering the patient themselves. That's most important. And we do eventually looking at this, it's like we are our own advocate. Um, or a very great tip of yours are like um, having your, what's it that, what is it? Like power of attorney or not?
Medical attorney.
Yeah. So
Yeah.
setting up like a power of
Yeah.
attorney.
You can get that even for your friends, or whomever. I think you're allowed multiple advocates because it's like when you're in the hospital, your advocate might not be able to be with you like 24/7. So then like your advocates kind of take turns. I personally only have my mom as my power of attorney, because that's just easier. But what I tell patients is that is your legal representative. That is your advocate. That's not your family member. That's not your friend. That's not a visitor. That's your legal representative. And so you legally are allowed to have an advocate with you, even if they tell you, oh, no one's allowed to come with you or no visitors allowed. Say, that's not my visitor. This is my legal representative. And they can't really argue with that paperwork. I mean, just always have that piece of paper with you.
Yeah. Oh, I think that's great. So, because a lot of people might not have their family member here. And sometimes it's important to know that actually your friend can that be virtually actually?
Um, I'm not sure. I
Or
mean,
do that have to be in person?
I guess if they're like on FaceTime or whatever, and then the patient themselves has the power of attorney with them printed out,
Hmm.
then that might be allowed. Um, for instance, one of my friends, they were just in the hospital and their friend was with them on FaceTime or on the phone. And although the friend themselves who was sick was like unconscious, the friend would hear anytime a doctor came in and would like talk to them and tell them what's going on. And so I thought that was pretty amazing because I actually didn't have a power of attorney or any way to help them. And they were like, no family allowed or no friends allowed. So I couldn't help them out and they're all alone, but they did have that.
Wow. Yeah. That would be great because I know that I become one of my friends advocate like I think just through the phone, and I actually
Yeah.
talk to the doctor, and they actually listen more. Um, Although eventually they still dismiss as FND and then send her home.
Yeah.
But I think in that process, and it's like you feel like the doctor can hear you a lot more, especially patients often in a weaker position
Mhm.
to speak up. So, any thoughts?
Yeah, definitely not only learn how to advocate for yourself, but have a backup advocate, because there's always going to be a situation in which you cannot advocate for yourself. That's just, how our health works. So I would definitely be prepared and be a proactive patient. So being a proactive patient can look a lot of different ways, but even just like already having your um, medication list printed out, all your doctors and their phone numbers and information printed out, maybe even your medical history, your diagnoses, um, your allergies, your insurance information, all that. So that everyone has that when you go into a new place or go into the ER, for example.
Yeah, and release a lot of panic, moments. And this is great. I'm really, really glad that you are able to be on the show and that really share so much of knowledge about patient care. And I think that's really, really important for what a lot of the guests are, and then what they are dealing with right now. So thank you. And thank you for tuning in to A Call Awareness. And remember, understanding starts with listening, and change begins with awareness. So stay connected and stay empowered, and join us next time as we continue to unravel the mysteries of health and that hidden the plant side. So until next time, take care. All right. Thank you so much. Thank you for joining us on this episode of Hidden Diagnosis Impact. We hope Kiera's story and insights have inspired you and provided valuable information for those navigating similar challenges. Remember, whether you are a patient, caregiver, or healthcare professional, your voice and advocacy are crucial in improving the healthcare system and supporting those with hidden diagnoses. If you enjoyed this episode, please subscribe, rate, and leave a review. Your feedback helps us reach more listeners and continue to share these important stories. You can also follow us on social media for updates, resources, and more inspiring content at Hidden Diagnosis Impact. Until next time, keep advocating for yourself and others. And stay tuned as we continue to uncover and understand the reality of these undiagnosed or underdiagnosed conditions. Thank you for listening.